Hello, good afternoon, good evening, or good morning, ladies and gentlemen. Welcome to another episode of EASL Studio. And today's episode is entitled Artificial Intelligence. Will it change the way we practice medicine forever? It's great to be joined by three members of the EASL Artificial Intelligence Task Force. I'll let them introduce themselves according to my screen. Ashley, you first, please.
Thank you. My name is Ashley Spann. I am a transplant hepatologist at Vanderbilt University Medical Center in the United States. And a lot of my focus, as well as an informaticist, is how we use different informatics tools, including AI, to improve liver disease care.
Thanks, Ashley. Sabela, you're next.
Hello, my name is Sabela. I am a pathologist at the hospital clinic in Barcelona. I'm also a member of the scientific committee at EASL, and I am the liaison between the governing board and the AI task force. I'm more of an AI user rather than expert. I'm very happy to be here.
Thanks, Sabela. I'm sure you've got lots to say and lots to input, so don't worry about that. Jakob, you're next.
Hi, thank you. Thank you so much. I'm Jakob. I'm a medical doctor in doing GI oncology in Dresden in Germany. I trained in hepatology and medical oncology, and I'm leading a research group at our university focusing on AI in healthcare. Thank you very much. It's great to be here.
That's great. So, guys, I think it's important to start by saying we've been talking about artificial intelligence for years. There's lots of sci-fi movies, for example, about artificial intelligence that predict the end of the world. But it really seems that the pace has really picked up in the last 1 to 2 years, partly with the introduction of large language models, which we'll come to talk about in a minute. But what's changed in the IT world? What technology has changed to enable such a big leap, it seems, in AI technology? Ashley, maybe I can start with you on that one.
Yeah, absolutely. I think that, we've been looking and dealing with AI for quite some time, as you mentioned, but I think more recently we've come into a space where we have not only have more computing power, we have cloud computing capabilities as well, but we also have more advanced technologies like transformers or our GPT models and large language models that are not only able to accomplish singular tasks that we provide these models, but also can go out and retrieve through the internet, through access to these other data sources, more information about how we might be able to utilize them and can garner that feedback and adjust and refine from there. I think that is something that has made a major step forward in how we think about how we can use AI and how we might be able to use it in healthcare.
Okay, so from a simple point of view, the computers are more strong, but they've also got more access. Jakob, is that right?
Yeah, it's and the only thing that I would add to what Ashley said is the data. So as you said, there's three ingredients to modern AI: algorithms, as Ashley said, the transformers that were invented a couple of years ago, compute, just scaling up, buying lots and lots and lots of graphics cards and training AI models on them, and data, the fact that people like downloaded all the text data from the whole internet and use that to train ChatGPT and other large language models. And we are seeing these three ingredients also mirrored in medical AI models, and that basically has made the has been responsible for the breakthroughs in the last couple of years that we hope to also bring to clinical practice now soon.
Great. So, Sabela, I know you say you're not an expert, but can you explain to us in simple terms what a large language model is? What's it able to do? And why is it important for medicine in particular?
Yeah, so large language models are like artificial intelligence systems that try to understand, to generate like the human language, right? And so it has completely changed the way that we communicate with computers. At least myself, when I Googled something, it was like, some just very specific keywords. And now with the LLMs, what we're doing is like, I want to do this because of this, and I'm going to explain to you why and what's the rationale, so that we are learning as well how to use these prompts, which is the way they're called, to really get the answers that we need in a very different way compared to when we were just Googling.
Okay, so large language models are sort of the front face of AI, if you like. Actually, presumably there's more to AI than just large language models. So maybe tell us about the non-large language models and what they are and how they may be used in medicine moving forwards.
Yeah, absolutely. I think AI exists on a spectrum, and I always try to think about it as augmented intelligence in the sense that it's providing things that we can do as humans, but in a more efficient manner. And I think of it that both AI and human together are better than either alone. When we think about different tasks that we might want to complete, whether that is pulling data out of our electronic health record systems, there are different tools that we can use for that. Natural language processing, large language models can assist with that. There are other things that we can do that are non-generative, such as creating predictive models off of data that we have and using that to train and refine how we might provide, say, decision support for different clinical scenarios. I think there's a wide spectrum of what we're able to do. We're more so recently kind of embedded heavily in the generative AI space, but non-generative AI has been around for a very long time, and we can do a lot with it. And I think there are scenarios where one might be better than the other depending on the clinical situation.
So Jakob, I mean, Ashley's used the terms generative and non-generative AI. If you were to talk to a 10-year-old, how would you explain to them that difference? Sorry, slightly challenging question, but how would you explain to a 10-year-old what the difference between generative and non-generative AI is?
Yeah, it's actually this difference has become less and less relevant now because the boundaries are blending now. So previously it was there was a clear separation in generative AI, so AI models that you train to create text or images, and non-generative or discriminative AI that you trained on data, and it basically gave you prediction as a number but it didn't talk to you like in language or in images. Now the boundaries are blending. Large language models are part of generative AI because they can not just ingest text but also output text, and therefore you can include them in chatbot user interfaces. So when you mention generative AI in the public, they basically think about ChatGPT and large language models, and that's generally correct. Although even before we had generative AI models that are now obsolete.
So it's
Sorry, that was not very straightforward. But
no.
it's
I think I
basically.
understand what you're saying. Anyone else want to add anything to that explanation? No? Okay, well, we'll move forward for that. So how do
Sorry,
yeah,
Ahmed, sorry, maybe one thing that I would like to, that for me is much more important than the difference between generative and non-generative AI is generalist AI, what
okay.
Ashley also mentioned previously, right? So 4 or 5 years ago, whenever we spoke about AI, we had one AI model for one task, okay? One AI model for ultrasound image analysis of the liver, one AI model for chest X-ray analysis, one AI model for text extraction. Now we have generalist models, large language models. The current large language models that we have access to, ChatGPT and others, are generalist models. You can ask them anything. You can show them an X-ray image. It will give you a decent description. You can ask it to extract key pieces of information from a medical report. So these are task agnostic models, generalist models, and I think that has really been the game changer here.
Okay, so as you say, task agnostic is very important because it actually enables you to come up potentially with results that you weren't expecting as well. Would that be fair?
Yeah, absolutely.
Yeah, okay, great. Well, we're sort of starting to transition into AI in medicine. So let's talk about that. So Sabela, as a user, how has your daily practice changed, say in the last 12 months with the onset of large language models? Give me an example.
I mean, it has certainly made my life easier, especially in, some very time-consuming tasks that now can be performed in a much more efficient way. And I think that time is a very valuable thing that we all appreciate. So either for writing documents or for exploiting databases, it's amazing all the power that it's included. I've been lucky enough as well to have been one of the few people that have had the opportunity to have a course to learn more about AI that was provided by my hospital. So during around 3 months, once a week, we had an expert in different AI processes, because AI is so wide and heterogeneous, showing us all the potential that we could get from these tools. And I have learned a lot to improve my day-to-day practice. Maybe in the clinical aspects, when treating or dealing with patients, it's more maybe knowledge or finding a specific question, the way that I use it, not so much for interacting with the patient. But I think that this is something that we are right now kind of building the path for that. I mean, it has changed a lot the clinical practice for sure, especially when you also work in academia, when I think that you can get the most profit from it.
Yeah, so that's interesting. So, I mean, training is an important aspect. Maybe we'll spend a couple of minutes talking about that. I mean, actually, it seems to me there does seem to be a training gap. Everyone talks about AI, yet actually no one trains us about AI, either as general public members or as doctors. So where do you see the benefit of training? Who do you think should deliver it? What should that training involve, if you like?
Yeah, absolutely. I think it's incredibly important on how we think about education around the use of AI. And I think that requires both thinking about it from a provider perspective and also a patient perspective. We need to be educating our providers on how to use these models. We need to be educating our providers on how to potentially interpret the results, make sure we're not dealing with potential hallucinations or false data that is clearly presented in a manner that should be true, but is actually not. We need to be able to educate our patients as well on how to use these models safely. Many patients are using these regardless of whether or not we want them to or not. So we need to make sure that we educate our patients on their use, because they'll come to us with things that they've identified using these large language models. We were in a scenario of dealing with Dr. Google. Now we're dealing with Dr. GPT, which is much more refined, and we need to be able to address whatever may come out on the other side of those. So I think it's important to include training around understanding how the data is getting into these models, how it's assessing it, what potential biases might be there, and how you might mitigate that with how you ask it questions or how you think about the results that come out.
So the risks with AI, which I'd like to address in a bit, but Jakob, I mean that's a really good point, isn't it? Is the patient will come to you now with much more focused AI generated answer. Now, how do I as a physician start to address or unpack that? And do I need more time? So actually might AI increase the amount of time I need to spend with the patient rather than reduce it? Maybe certainly in the short term, while the language models are improving.
Yeah, absolutely. I mean, first of all, I think that we have to acknowledge that it's a good thing that the patients are using ChatGPT and that they're asking their questions, right? I mean, we want to empower patients. Anything that they are doing, reading about their disease, talking to ChatGPT, talking to their neighbor, whatever, they can do whatever they want. And I think it's good that they take different information sources and are not just dependent on us in the consultation, right? At the same time, and I think it's much safer in many cases. It's much safer to ask something to ChatGPT than to ask it to Google. I mean, we have not quantified this. Actually, we should do a study about this. But just by Googling stuff, you can get really. I mean, many of the top hits are in many cases it can be misinformation, especially in the cancer space. So ChatGPT generally gives you, I think, much safer results. On the other hand, of course, there are some hallucinations going on there. There is potential misinformation there. So of course, we have to always take the information with a grain of salt. One more thing I would like to add is the legal perspective here. If we as if you are a doctor, you cannot use ChatGPT for medical decision making in the US or in the EU. This is any AI software that directly informs clinical decisions is classified as a medical device, right? It's the same as a cardiac pacemaker or or any other medical device. It's a medical device, so it needs it needs certain approval. In the EU, for example, it needs a CE mark. Now ChatGPT and other large language models do not have this, so we cannot use it for direct clinical decision making. Of course, we can use it just like we use Google or we read different sources. We can use it out of curiosity, but it can, of course, never make any decision. That's an important point. The other thing is never put any patient names into the commercial version of ChatGPT. If your hospital gives you access to a fully HIPAA, GDPR, everything compliant large language model, then that's great, and you can use it more freely. But just a commercial version on your personal phone, please don't put any patient names or any sensitive information in there. But at the same time, I think we should encourage everybody to just play around with this as much as possible, because I think that's the best way to obtain this this literacy ultimately.
So that's an interesting question. It's a really important practical points, Jakob. So are there moves from the large language model companies, and we know that many of them are massive tech companies, to get their large language modules registered as medical devices? Is that a move, or is that not happening yet?
That's a move by, I mean, there's certainly movement in the area. There's hundreds of companies that are aiming to get large language model based chatbots to the market as medical devices. This typically takes at least 18 months. So I think we can see much more of this coming out in like this year and next year. I don't think it's the big tech companies per se, because for them healthcare is just one. I mean, healthcare is just associated with so much headache, and it's just one area. But for sure, the big tech companies are marketing tools specifically for healthcare, like, for example, the whole Microsoft AI for healthcare stuff that they're presenting, but also basically any big tech company.
Great, thank you. So Sabela, I want to use this question I'm about to ask you to transition to academia, and then we'll talk about a bit the risks associated with AI. But when we hear a research finding, so X does this, we often then look at what the source is, what the journal is, what the impact factor of the journal is, not necessarily always correctly, because some less than ideal research gets into high impact factor journals and vice versa. But we have some sort of filters that we're taught to go through as practicing clinicians, as academics. Now, with large language models, it depends on the input as to what you get out. How do we start to train ourselves to critically assess large language models? As maybe, is there a transition phase that we're going to go through, so that in 5 years, actually, all this learning, the models will have learned enough to know that actually these are the reputable sources that I should give more weight to. These are the less reputable sources that if I give some advice or give some information, I should caveat the information. So what are your thoughts?
I think there's a learning curve from both sides. So one, the user, you need to practice, you need to learn how to interact, you need to learn how to get the best answers that you're looking for. And I think the best way of doing that is, just practicing. Of course, you can get some tips which are very useful, especially when you start. And then there's also probably a learning curve from the other side. So, for example, the Spanish Society for the Study of the Liver, they have developed a liver AI tool that is specifically trained to answer questions related about liver diseases. And you see how it really improves the question or the answers that you receive when you compare it to the general LLM models. So that's also a way that the users are, taking to fill in these gaps for their needs.
Okay, so that makes sense. So it's, again, an iterative process. We've used that word a few times, and it's something that we need to learn. So in academia, actually, there's this perception that that using AI is cheating. Okay, and in fact, I was interested recently. One of my children said actually we were encouraged to use AI to help them write a piece, but then they were asked to critically evaluate the evidence that the AI model produces. Are we at risk of losing those skills in 5 years' time? And what happens to the new generation coming up? So, question to you, is using AI in academia cheating?
That's a very loaded question. I would say that, I think it's dependent on how you're using it and the purposes that you have behind it. I think it's one thing to ask a GPT model to generate an entire block of text for you for a manuscript. It's another thing to use a GPT model to refine what you've already written so it's more readable. I think those are completely two different scenarios in which one might be more appropriate than the other to do. And we have to think about how can we not only address what are ethical ways to do this from an academia standpoint, but also how can we provide potential frameworks and guidance for people who want to use these things. We also see, issues with publications when there are issues with readability, depending on where they might be published. Can we use GPT models to help support that so that good science can still get published without having to worry about concerns about readability? I think that's a big concern and question that we need to think about as an academic environment on how we're going to really leverage these tools for good uses as opposed to potentially more harmful ones.
So, Jakob, I know some journals will prevent you using any artificial intelligence in your review of your papers. Do you think that's a bit short-sighted? Again, I'm asking loads of loaded questions, but I think it's interesting to the audience to think about things like this. So what are your thoughts around that?
Yes, I think that it's quite obvious that you cannot stop this, and you also should not stop this, right? Of course, you should not have your whole paper written by AI, but most of the journals allow you to edit the text, and we typically put in our either in the methods in an original research article. We usually put in the methods section one sentence on ChatGPT or Claude or whatever large language model was used to refine the language and fix spelling mistakes or whatever, and or if it's not a piece that has not an original research piece that has a methods part, we put it in the disclosures. And that's actually how my advice would be to anyone to just check the journal guidelines for this, and actually most of the big journals have these types of guidelines. Of course, there's no other way, right? You cannot ban it, and I think as an what we are still pretty good like garbage detectors as humans. Like as an editor, I'm handling many manuscripts, and you immediately spot the ones that were just written by ChatGPT, because they're just bad and superficial. But also there's some human written bad and superficial articles that you don't consider further. So I don't think it's the end of scientific publishing, at least when it comes to original research, right? I think it's different for literature reviews. We have to really acknowledge, I think, as the scientific community, that probably systematic reviews as they were in the past are dead, right? So these tools are now becoming so good, even if they're now not good enough in 2-3 years. Doing a systematic review that would take a human 6 months can be delivered. That's basically my bet. Can be delivered in exactly the same quality by a large language model based agent with access to all of these articles that you then refine as a human. But that's okay. I think the core part for me, that's okay. The core part of science, like original research with experiments and data, this is not going to go away.
So in a way, doing research has become a bit more difficult because the low-hanging fruit of people who do meta-analyses, systematic reviews, maybe as a start to doing more serious research, that's going to just all go, isn't it, in some ways? But in a way, could artificial intelligence allow us to identify massive research gaps that we wouldn't otherwise see as human beings?
Yeah, that's the dream. However, we have very little empirical data for this. I mean, there have been occasional papers that large language models have basically proven a mathematical theorem that was unproved, that was where nobody found a proof for decades, right? There are occasional papers that AI found like some new chemical. I think there was like a Nature paper on new psychoactive drugs or something like this. But these are really occasional pieces of evidence. For me, this is not enough yet to say that large language models are creative enough to guide us through or to completely autonomously fill like gaps in the research that have eluded us humans. I guess we will get there in a couple of years, but this is still stuff of the future, I think. Yeah.
Yeah, there's been some information about, drug repurposing and using large language models to identify potential scenarios where you can do that. So I definitely think that, that may be something that ought be on the horizon. But I think an even more important point is that these models have the ability to generate text, generate data, potentially synthetic data that can then be used to augment other models. So I think we're going to be in a space where these models can help improve the efficacy and efficiency of other models that we might create for different purposes.
So on that note, actually,
maybe Ahmed, can we ask you a question? Did you use ChatGPT to create today's questions for this
No, I
episode?
didn't, but I am
Maybe you
a
should
slow
have.
adopter.
Maybe
I'm a slow adopter, but I mean, I think I use ChatGPT often to refine titles of things. Where I think actually it's not quite saying what I wanted to do, and sometimes it comes up with some really good suggestions. I have my personal experiences. I only once took a paper that I was being sent to review and put it in a ChatGPT and saw what it was. I'd read the paper and made up my mind anyway, but just as an exercise for myself, did that, and then actually came up with some very good points that I'd already thought about, maybe one or two that I hadn't thought about. So I think there is definitely scope there, absolutely. But I suppose my question,
we put all of our sorry to interrupt, but we put all of our own papers through ChatGPT before submitting them. Like, are there obvious weaknesses, internal inconsistencies, etc. And usually it does not find any, which we're happy about. But sometimes it does, right? And of course, all the time it finds like figure 4 was referenced before figure 3, etc. This kind of stuff.
So Sabela, I'm going to throw this one to you, and then we'll come back to some of the other risks associated. Is there any evidence yet that artificial intelligence has improved patient-related outcomes?
I don't know, to be honest.
Anyone else want to answer that question?
I would say from a patient satisfaction standpoint. So this is in speaking directly to things like ambient AI documentation. Clinically, I can personally say that when I use ambient AI documentation during my clinical visits, I'm now able to
I'm going to interrupt you. What do you mean by ambient AI documentation? I
think I know,
but just clarifying for the audience.
Yeah, absolutely. So it's a AI model that is listening to the conversation that I'm having with the patient, recording the conversation, transcribing that, and then creating a note based off of the discussion that we had and everything that we've talked about. By using that, I would say personally, I felt that I'm better able to have a direct face-to-face conversation with the patient, not necessarily having to worry so much about trying to type things into the computer, and can get more out of the patient in that interaction. And I think some studies have shown that it's not only lessened the time that it takes to complete documentation, but there is some signal for patient satisfaction being improved as a result of that. So I definitely think that there are scenarios where we can use AI that can improve those sorts of patient outcomes.
And we sort of use that a bit because we have, immediate dictation that gets transcribed automatically. So we're already down that path, I suppose, aren't we? So, I mean, question to you all. I mean, we could describe that as a menial task, clinical noting at the time. But what that does sometimes allow us to do is think. And it also gives us a bit of headspace to process and do things like that. Is there a danger by removing all so-called menial tasks that we put more pressure on ourselves as human beings, as doctors performing? So we're not giving ourselves that, if you like, headspace that we sometimes need just to process and be human beings. It's a question. Do people understand what I'm trying to say? That actually you end up putting even more pressure to complete even more tasks in even a shorter time. So who wants to take that one?
I think Ashley's example was more into the opposite way, right? I mean, AI helping to improve human interaction and to extend that face-to-face contact that we need with the patients or with other partners. And I think that AI can really help in these time-consuming activities that do not add much to any of the human interactions or to thinking of new projects and new ideas because we are just overwhelmed with so much administrative work. So I think that right now it's the other way around. In the future, let's see, because this is evolving so fast. So let's see what happens. But
Okay, so if I ask you to all do a little bit of future gazing for me, coming up to the end of the episode now, in 2 years' time, how do you think your day-to-day practice, clinical practice or research practice, I'll let you choose whichever you want to do, will be different in mid-2027 compared to mid-2025? Ashley, you go first.
Yeah. I will take it from the lens of the research practice, because a lot of my research practice actually blends with operations. So much of the work that I do right now is thinking about how do we get these models in front of people who need to use them inside of their electronic health record environment. I envision in a couple of years that we'll be in a situation where we'll have the ability to get these models directly in front of both providers and patients in a way that is well evaluated, rigorously tested. We're accurately monitoring for potential algorithmic bias and addressing those scenarios because we've been thinking about this for quite some time. So I envision that we'll be at a point where we'll be in a position to study these models in actual practice and how they might affect different clinical outcomes.
Okay, great. Jakob, same question to you.
Yeah, and unfortunately, I'm thinking about the clinical practice, and I think unfortunately our healthcare systems here are very slow moving, right? I mean, we're still faxing stuff and printing. Patients come to me with printed letters from other departments of my own hospital, so it's and we don't have ambient AI scribes as Ashley has, so we are in a developing country basically here, and I think we have to solve some of these hurdles, these digitalization hurdles in the first place, because in 2 years there will be many CE marked products on the market that can help us in clinical decision making. There will be evidence that these are helpful. So I hope that this is going to create pressure to basically modernize our systems, but this is something that we really have to do now. Otherwise, I think people will just use AI tools on their personal phones or personal devices, or patients will just use non-approved tools. Doctors will use none. So I think we cannot. It's unstoppable. Either it will be like a complete shadow market, or we will be able to modernize our healthcare system sufficiently so that we can actually implement all of these tools. But that's going to be quite a task.
Sabela, it sounds like you're in a healthcare system that is a bit more advanced, maybe. So how do you see yourself different in 2 years' time?
No, I agree with Jakob that we have a lot of barriers that are gonna be necessary to overcome in order to foresee in the future that these AI systems are integrated into the clinical workflows, and we, completely forget what was to fill in databases in order to do some clinical research. And if a question comes to our mind during our outpatient clinics, if we are able, to have all the data integrated and we're able, to extract the data that we need to answer the specific question that we have in our mind in order to make a clinical decision, I think that will be there. But as Jakob said, we have barriers, these informatics systems that sometimes are so difficult, to really modify or to soften at each hospital, each region of each country. And also, of course, we have to work a lot, and there is still a lot to be done on legal issues. And we also need to generate this trust and acceptance, not only in the clinicians, in the healthcare providers, but also in patients, which sometimes it's also going to represent a challenge in the future.
Okay, so it strikes me that one of the things we may see is health inequalities between systems that are early adopters and late adopters, and maybe that's what will drive the political agenda ultimately. I don't know, that's the impression I get from speaking to you guys. Agreed or disagreed?
Yeah, I agree. I think
Agree.
interoperability between sites is going to be a big issue, and it's going to require policy level changes, whether that's in the US or in the EU, to make that happen. I think with the COVID pandemic, we moved a lot towards telehealth, and there was a big push around policy nationally, internationally to make those things happen. I think we need similar pushes towards making these things interoperable between systems to make sure that we can put us in a scenario where we can equally have access to these tools.
Okay,
So
and one
countries that
final
have
question. Sorry,
countries that
Sabela.
have an integrated healthcare system will probably have an advantage in that sense. This is something that doesn't happen in Spain as well. So every region has a different healthcare system, different informatic tools, and this is going to be a major barrier as well, and it's going to create an inequity in accessing these tools.
So we need to advocate from now for connectivity and better data, essentially, to enable these questions to be answered. No, I totally get that. So one final very provocative question, more not related to medicine, and I want a yes or no answer. And I'd like to thank you all for your time. But will AI be the end of humanity? That's a question that everyone asks. So everyone's fear. Go on, yes or no, Ashley?
I'm going to say no.
Okay, Sabela?
Definitely no.
Okay, and Jakob?
But not yet. I mean, not now. Let's yeah, not
Not in
now.
the
Maybe
next
we
5
can
to 10 years, anyway.
not in the next 5 years.
Yeah,
Yeah.
okay, great. Okay, well, on that optimistic note, I'd like to thank you all for joining. I think it was a great discussion, very interesting. Thank you, Ashley. Thank you, Sabela. Thank you, Jakob. And please join us next week for another EASL Studio entitled Steatotic Liver Disease Unpacked, Targeting Dynamic Risks, which is very much about diagnosing and personalizing treatment in steatotic liver disease and how we can address cardiometabolic risk and also the dynamic nature of alcohol intake in our patients with SLD. Thank you very much to the audience for listening, and I wish you a good evening, afternoon, or morning, wherever you are. Bye-bye for now.